Good morning, everyone. It is Wednesday. You're in the House Healthcare Committee. We have a busy day, but we are going to start out today with the Vermont Medical Society, as it is Vermont Medical Society Day. So we'll bring, I don't know who's coming to the table, but come on up. We do have one member on screen, just so you know.
Okay, and should I plug this in?
If you have a slide, yes.
I
Yep.
have a slide deck. It's on your website, but I can also.
What does everyone want to do? We've been putting them up, or does everyone want to do it on the?
I put it on my laptop, but I'm happy to have it up too.
Yeah, okay, let's put it up. Bobby, just remember you have to text me if you have a question, because I can't see you.
So you'll have to join the Zoom.
Oh, okay.
I can send it again.
I can do that.
Ladybugs are like my reminder.
Oh.
I was your mother.
Yeah, coming to say hi.
Coming to say hi on Melissa's laptop.
I guess while Jessica's doing that, I'm going to update the committee. There's been some changes. We sent an email, but just for general public knowledge too. We are moving workforce conversation to tomorrow. That was supposed to happen this morning. And we're going to, after Vermont Medical Society, Ina Backus will be back, and we will finish the conversation we started yesterday on the history of the all-payer model and what it is, and then move into what's happening today for the next iteration of the all-payer model. And then we will still have something at 11, and then we'll have Department of Mental Health budget this afternoon. And then we will, remember, we're joining the Green Mountain Care Board meeting. So again, we won't be in their meeting. We will be watching their meeting as a committee. And I've let the House Majority Leader know that we're going to stay in committee unless she lets me know that we need to go down and vote. If you prefer to be on the floor, that is your choice. Please go to the floor, or we'll stay and just watch the meeting. So we won't be asking questions of the Green Mountain Care Board. So I would say keep a list of questions if you have them, and it'll be something we can follow up with them at a later date. Okay, any questions? All right, good.
All right. On my screen, it's not showing the. Oh, there we go.
Oh, yeah. Oh, good. And we can see Bobby still. So perfect.
Should be up. Okay. Well, thank you so much. Sorry for taking a minute to connect in there. I'm Jessa Barnard, the Executive Director of the Medical Society, and I am joined by my two colleagues who you may also see in the building, Stephanie Winters, our Deputy Director, and Joel Sadov-Garin, our Communications and Policy Consultant. So we have a no wrong door reaching out. All of our contact information is on here. Feel free to reach out to any of us if you have questions or issues you want to discuss with us. I'll kind of go through the range of our projects and areas of interest so you know when you might want to talk to us and who we are. And we do tend to divide issues up by bill between the three of us, but not entirely. So just as I said, reach out to any of us at any time. So why are we here? Who are we? We represent physicians, physician assistants, and physicians in training, medical students and residents. We were founded in 1784, we've been around for a little while. We estimate we represent about 2/3 of practicing physicians in the state. It's a little hard, our membership doesn't line up exactly with practicing physicians because we have retired members, medical students, so it's not quite a one-to-one, but the majority of physicians are our members. And we're kind of like the Bar Association, the Dental Society, we're a professional association. We represent physicians and other clinicians of all specialties and all practice settings. So not just one employer type. They could be at a hospital, could be at a federally qualified health center, could be an independent practice. We do have some group memberships. So sometimes a hospital or health system or FQHC may support all of their physicians joining us as a group, or we also have individual members. Our mission is to protect the health of all Vermonters and improve the environment in which physicians and physician assistants practice medicine. So we really cover the range of healthcare and public health issues that you consider in this committee. Pretty much every bill you might take up in here, we care about. We don't testify on all of them, but we may have members submit letters or submit testimony in writing. We do often love to be here to testify, either ourselves as staff, or we could bring in our members to share with you their perspective of what it's like to practice medicine or how the issue you're taking up impacts their ability to practice or take care of their patients. So we are the staff side of the team. We are not clinicians, so don't ask us a medical question. None of us are physicians by training, but our members and our leadership are. So right now, our president is an emergency medicine physician at NBRH who is very passionate about a number of issues like.
I'm sorry, just say what NBR.
Sorry, Northwestern Vermont Medical Center, Northeastern Vermont Medical Center. Thank you. And he will actually be here. So a later slide we'll be talking about. We have a reception this evening, as the chair said. Today is our advocacy day. He will be here. He will be speaking this at our reception. So issues he feels particularly passionate about are wait times in emergency departments, access to mental health services, violence against healthcare workers. So those will be some of the issues he probably is speaking about this evening. Our president-elect is a pediatric intensivist. That means she takes care of our sickest, most vulnerable babies and little children at the inpatient department at UVM Medical Center. Our vice president is a family physician at a federally qualified health center, and our immediate past president is a psychiatrist from the Howard Center. So we really try to have our board and our leadership reflect kind of the breadth of types of practice settings and also specialties. Just a little, this is our board is even broader representation from around the state. I won't go into detail on that. And we also get input from our members. It's how we decide which bills or which issues to get involved in comes from our membership. We almost every year we do a physician and PA member survey. We have the results posted, and this year was really striking to me. I mean, I'm sure you hear it from your constituents, you hear it in the press, but just the level of stress that healthcare providers are under right now is incredible and enormous, and frankly, a little almost overwhelming to feel like, how are we going to help solve some of these issues? So we got comments like the overall morale of physicians is low as I've ever seen it. One member wrote, "I don't have time to just be human." I mean, just the amount of patient needs, administrative burden, issues they're taking on is really hard right now. On the other hand, they're so, as you know, I'm sure I don't need to tell you this, but so dedicated to doing what they're doing. They love their relationship with their patients, their community, their practice. That's why they keep coming back every day despite being so overwhelmed. So I encourage you to take a more in-depth look at the survey. We asked about some issues your committee cares about, what impacts your ability to practice medicine. We asked about kind of ideas around workforce development, how to strengthen the healthcare workforce. So there's a lot in there. This slide just pulls out some of the key issues impacting their ability to care for patients. So workforce, all the physicians, nurses, medical assistants, reimbursement and compensation. I'll talk a little bit about that more in a bit. And then some of the loss of autonomy issues or lack of the supportive kind of workplace. So those were some of the feedback we got. So what do we do with that information? We try as an association representing these members to then bring that to action. How can we support our members? How can we address these issues? A lot of it is advocacy related, but I do want to touch on a couple of our other programs just so you know kind of what else we do and how we might be able to get you information or resources for your constituents or communities. So we also serve as the kind of administrative home for a number of medical specialty society organizations. So as Vermont Medical Society as a whole, we represent all specialties, but there are also specialty organizations have their own boards, own structures, but we provide them support. Stephanie is actually the executive director of a number of them. If you ever get her email signature line, you'll see how many organizations she actually runs. She wears a lot of hats. So we support the pediatricians, the family physicians, the surgeons, the ophthalmologists, the orthopedists, the psychiatrists. So if you have a constituent question, or if your committee is taking up an issue that's kind of specific to a specialty, especially maybe, for example, children's health, the pediatricians are very active in advocacy. So you may hear from VMS, you may hear from AAP Vermont, the American Academy of Pediatrics, or we often do joint testimony, joint letters. We run a program, and this is something that on occasion has come up in this committee. It's called the Vermont Practitioner Health Program. The Board of Medical Practice, who licenses MDs, physician assistants, podiatrists, radiology assistants, anesthesia assistants, charges a surcharge on licensing fees that then the Department of Health does an RFP process. We have been the successful bidder for that program to support board licensees who have an impaired ability to practice medicine from either substance use disorder or other mental or physical health conditions. So we have a psychiatrist who's the medical director of that program, and one of our staff members who's not here with us today is the administrator. So again, if you have a clinician in your community who's struggling or you hear of this issue, we'd be happy to give you resources, connect you with that. And then physician and other clinician wellness is top of mind, again, given all the issues I've spoken about. So beyond the practitioner health program, we have a grant to provide no cost sort of well-being workshops to medical staffs and other medical practices. We have launched this year a clinician well-being collaborative. We have a facilitator who's bringing together sort of healthcare wellness champions from around the state to talk about best practices, share best practices with other medical staffs or medical practices, and support each other in that work. Because that can be really lonely if you're at a small medical practice or the chief medical officer of your hospital and you're trying to improve clinician well-being. Where do you even start? How do you advance those initiatives within your institution? So this is kind of a peer learning network working on those issues. We run a clinician leadership course that has ranging between about 14 to 20 members each year. This is our 4th year of running that. So again, trying to elevate physicians, PAs, clinician leaders to not just be caregivers for patients, but how do they actually help improve our healthcare system, improve their practice environment. So that our 4th class just launched this January. We have a small fund that each year grants a medical student scholarship. So we support the next generation of physicians training and staying in Vermont. And we also have a lot of educational resources on our website. The one I really wanted to point out to you is our Vermont Guide to Healthcare Law. I know you have excellent legislative counsel and resources here in-house, but also if you just, 2 a.m. have a question, this constituent is having trouble accessing their medical records, or, can a minor consent to reproductive healthcare services? It's actually, each chapter is written by healthcare lawyers from around the state. So we kind of have volunteer authors of each chapter, and it covers a huge mental health. It covers, involuntary mental health treatment, a whole bunch of issues. So if you have health legal questions, please take a look at that. So, and then to the heart of it, our work, we focus on advocacy quite a bit, not just during the legislative session, but with the Green Mountain Care Board, with the administrative agencies kind of year round, but certainly with the legislature as well. Last year, we launched in conjunction with our partners, as I mentioned, at the American Academy of Pediatrics and family physicians, a primary care campaign. All clinicians are struggling, but primary care practices right now are really on the brink of financial survival, not being able to replace themselves with new physicians, PAs, APRNs coming in to staff them. So we are really concerned for the future of primary care. And so we focused our efforts on a number of buckets. And I won't really go into the details on each of these issues because I know you're going to take them up in more detail later on, and we'd love to come back and talk to you in more detail. But our primary care efforts have really focused on sort of sustainable funding, workforce, and administrative burden. So again, happy to talk more on any of those details.
Go ahead. I have a couple questions, but I don't know that you only have a little time. So
Why don't we let her go through the
Yeah.
presentation and then we'll have time for questions.
Yes.
Perfect. Great. Yeah. I won't go into too much detail. And I will say I want to thank the current members and the former members of this committee. You have always been a great advocate for primary care, and in the past couple of sessions have made some really important inroads. So, for example, several of the members of this committee pushed really hard to make sure that primary care reimbursements was meeting, in Vermont, Medicaid's program was meeting Medicare's program rates. And they actually, the administration has to either fund primary care at 100% or come back and tell you what that gap would be. You asked for a study of expanding the Blueprint for Health community health teams. And I know you're going to be hearing more about the Blueprint for Health very soon, maybe tomorrow. A lot of important workforce initiatives have already passed, including what we're really excited about, funding 10 primary care incentive scholarships. So this is I think would only be the second year of up to 10 students studying at the Larner College of Medicine at UVM. For each year they commit to practicing primary care after they finish their training. The state budget would fund repaying a year of their in-state tuition equivalent. So that's, 10 more primary care physicians per year would make huge inroads for our primary care needs. So
You say 10.
10, up to 10 per year. Yep.
So you know what? I'm not going to ask a question.
You increase loan repayment for primary care. There's a new workforce recruitment and retention program that I say should be made available this fall. It has not been made available yet. I'm actually not sure the timing of that. We're hoping very soon. And also you've expanded coverage for primary care services recently. So no cost primary care services in every standard insurance plan. So those are some great successes. More we want to work on. We are actually really concerned that Medicaid rates could be going down this year because Medicare has gone down. So often that works to Vermont's favor, and that you've linked the primary care rates in Medicaid to Medicare primary care rates. But that means when Medicare makes cuts, that could mean cuts in Vermont. And we really have much less control over Congress, unfortunately. So we're watching that. We have not heard from DVHA one way or another on that. Hopefully we'll know more with the budget at the end of this week. We're looking for the blueprint report coming back. We care a lot about telehealth. That's an issue we've worked on for years with this committee, but currently still working on making sure that coverage for audio only, so telephone visits, continues. And actually I want to mention, because I know your committee has asked some questions about this, it's not on our list, but top of our mind right now is the loss of Blue Cross participating in the state ACO. We're really concerned that the impact, there are a couple of ways that impacts primary care. I'm actually working on a memo on this topic that I will get to your committee shortly, but primary care stands to lose up to $2 million across the network because of no longer having as the same number of attributed patients part of the program. So that would, if that does come to fruition, if Blue Cross does not rejoin the program, that really stands to have some real world impacts on primary care sustainability. Again, I won't go into more detail on this. I'll just say high level workforce issues. So the loan repayment and scholarships, training programs, administrative burden. So that's really the prior authorizations. I actually heard a committee member ask yesterday about, being on the phone, their doctor's office being on the phone call to get medication approved. So the length of time that offices, whether it's the clinician, the staff, are spending on the phone, on their computer, submitting paperwork, trying to get things approved, and that usually ultimately get approved anyway, but could take hours, days, weeks to go through that process. So how can we get our, and then we have, each payer has their own set of requirements. So how do we try to get some of this streamlined, reduced, more consistent? And then our members are extremely passionate about public health issues. So they really care about their patients, their patient well-being. So this runs from gun violence prevention, suicide prevention, access to mental health services. We're really happy that the legislature seems interested this year in taking up what they've been calling a shield law for providers of reproductive health care services. And then substance use disorder policies, funding. We've been very involved in trying to get public health protections in our retail market for cannabis sales. And now we're kind of working on keeping what we have, because we have heard fairly public efforts to actually roll back some of those protections, that the House in particular has been a really key champion of saying, okay, we understand there's a reason to have a regulated market, but let's not promote use to youth. Let's not advertise more than we are constitutionally required to. So we've really appreciated the House's support on that, and we'll be working on that this session. So that was a very quick run through of a number of our issues. Again, we will have members, hopefully at least 30 physicians and PAs here this afternoon to talk to you, let you know the issues they care about, what they're seeing with their patients day to day. We'll be in the cafeteria from 4 to 6. There will be food. So we hope you're able to join us. And thank you for giving us some time this morning. We really look forward to working with you this whole day. And again, please reach out anytime with questions or to talk more in depth about any of these issues.
Great. Thank you, Jessa. I'll take questions. Stop her, and then I'll go to Leslie.
I have 3 or 4.
Go for it.
In your mission statement, you talk about improving the environment in which physicians work. How do you do that?
That's really the workforce and administrative burden pieces. So when we say environment, we don't necessarily mean, our members actually do care about climate change, but not that type of environment. Like the actual, like, how do we make it more? So there are some things we can solve and some things we can't solve in the practice of medicine, but are there things that we can actually make some inroads on, like the amount of time on paperwork versus caring for patients? So reducing that paperwork burden, the time in front of a computer rather than actually, speaking face to face to your patient.
Have you been able to do that?
We have been trying. We worked with your committee really closely. It's actually 3 years ago now because I lose track because we extended some of the deadlines because of COVID, but there was Act 140 that included a number of studies on prior authorization and how to come at it from a number of angles. So one solution is actually technological. Can we build more of this process into the electronic medical record? You're already in front of the computer, the clinician's already in front of the computer documenting the patient's health condition, their other medications, all of that. Could that just automatically basically put a request in to the insurer that could automatically come back and approve it or not approve it? So there are some things, maybe we won't get rid of prior authorization, but we could make it easier. Maybe we could have all the payers kind of align their prior authorization processes. So there's a number of reports that either have or are coming back to your committee, and we look forward to building on those and maybe taking some steps further beyond that.
The other question I have is the $10,000 and then all the scholarship stuff. Is that hooked to AHEC?
I want to make sure I get this right. I believe AHEC does have, because there was a lot of back and forth between AHEC and VSAC. I believe AHEC does have they work with the Lerner College of Medicine on the student scholarship, and then they administer the loan repayment program for primary care. The $10,000 one, the Mildred Reardon Scholarship, is actually one internal to the Medical Society. So we administer that one ourselves. That's just one per year. But the other bigger programs the state-funded programs are through AHEC and then the Lerner College of Medicine on the scholarship one.
And I'm sorry, real quick, AHEC is?
Area Health Education Centers, which are housed at the Department of Primary Care at the University of Vermont.
Right.
And there's a home base in Burlington, and then they have sites around the state.
And these are a couple of easy ones. Are there enough primary care physicians in Vermont now?
No. And actually AHEC does a really good, it's again, like I know you've been hearing how delayed various data is. They actually do a really great report I encourage you to look at. It's called the Primary Care Snapshot. And it talks about how many primary care clinicians there are, where they're located, how many FTEs, how the shortened, and they compare it to benchmarks, kind of how short we are. And it's county by county. So you could look in your county and see how many more pediatricians or internal medicine docs do we need.
The last one, home health and hospice. What's the connection between that program and those community teams?
Oh, the community health teams. I would save that question for the blueprint presentation, because the community health team staff tend to be social workers, counselors, maybe nutritionists, and care coordinators. So but I could confirm with the blueprint that it's more of a referral relationship, that they may be making referrals to home health and hospice, but I don't think they tend to be home health or hospice staff that are those community health teams. Because those people are embedded in a primary care practice. So they spend a certain number of hours each week in typically maybe several primary care practices. So they're not the ones sort of out doing home visits like home health would. Sure.
So Leslie, did you have any?
If that's okay.
Yep, and then we have Art and then Mari. So let's try and do like 5 minutes and then.
Well, I'm curious about the 12% increased primary care to 12%. That seems like a low number to me. That means 82% is or 88%, is elsewhere. So why that? And can't we do more? Because I think we need it more.
Yes, we could do more. That is a number taken by Rhode Island and Oregon. So the few states out there that have set similar regulatory requirements to have a minimum primary care spend. That is, and I would have to go back and sort of look at the data to remind myself why they picked that number. But that number, it has been shown in those states to be achievable with minimal impact on the other. We could say 50% should be primary care, and I would probably accept, obviously there's also a need for acute care, hospital care. So it has to be incremental. It has to be kind of over time, but that is a benchmark to at least work
Yeah,
towards.
but it does mean that, well, we've talked about this before, social determinants of health and, and I didn't see that you mentioned any of that in your organization's thinking about that, especially dentistry, which is interesting in your presentation. But how do we get a healthier population? I would hope that the societies that you represent would want to think about that and embed it in your work.
Absolutely. Well, and we tend to call it, we use the term public health often. So all, those sort of primary prevention strategies. Absolutely. We can, we work actually a lot. We couldn't put everything on this list, but tobacco prevention, substance use disorder prevention, early intervention, obesity, early intervention with children. I mean, absolutely. Our members care very strongly about those issues.
Yeah.
And I will say, just again, not to skip too much into your ACO topic, but one of the reasons an ACO holds promise is that it actually creates that legal structure in which entities can shift their budget and their spending from acute care to community care. Otherwise a hospital can't just decide one day to take some of its budget. I mean, maybe they could, I don't know. They can't really share budget information with a home health agency or a designated agency, but an ACO gives a structure to say, actually, we can collect some hospital dues and hospital funds and then try to shift that upstream to prevention services, primary care services. So that is one way to actually start structurally making some of those shifts in where we're spending our money.
So can global budgeting do that too? Global hospital, I mean, that's on the table.
It's on the table. I would say it is, I think it is a little bit harder because that is a global budget for one entity, right? That's saying we want to shift how we pay the hospital only. And typically it doesn't include the other community services or other types of entities. It's just a budget for the hospital. So would there be ways to create linkages? Yes, but I don't think it's as, it's a different structure. And I don't think I think that's actually something that this committee, and I know AHS and others are thinking about this when we're thinking about other models, but like, how do you not lose that connection between other types of providers?
So we had one follow-up question, then we're going back to Art.
Yeah, just for frame of reference, building on Leslie's 12%, where do we think we are right now in Vermont?
Good question.
There is a report that was pre-COVID that it differs by payer. So, and that's not totally surprising because payers have different ages and risks of their population. Medicaid actually is well above that. They're the best, the highest above, I don't remember the numbers, maybe close to 20%. Medicare is the lowest. They were around 6%. And then the commercial payers were kind of in between, maybe around 8 or 9%.
Thanks.
Art?
Yeah, I was approached by a constituent, and Mari, you may know about this. I think she talked to you about using nurse practitioners as having the same role as PAs. I don't know a lot about it, but I was approached with it that, a nurse practitioner is as well trained as a PA sometimes, and that they could maybe take the burden off PAs and what they do. And I didn't know if that was an initiative that was out there.
That I would be interested to know more of the details because after having a 2-year collaborative practice requirement, APRN or advanced nurse practitioners in Vermont have full independent practice, where actually PAs don't in the same way. They have to maintain a collaborative practice agreement for their whole career. So I don't know if there was a specific sort of regulatory barrier they were referring to. I'm not sure because I know a lot of practices absolutely rely on APRNs. They have their own panel of patients. They practice independently.
Oh, really?
So yeah, they're used.
That's used now.
Oh, absolutely. Yeah, absolutely.
That was my job.
Oh, really?
Yeah. I could talk to you about it.
Okay,
Yeah,
yeah,
great,
all right,
great.
wonderful, thank you.
All right.
I was just going to point out the issue about not enough primary care providers. I called around maybe 3 weeks ago, just checking to see what the status was like in different practices. And every single one of them was not taking new patients, and most of them had a year-long waiting list.
Yeah, that doesn't surprise me. And especially as we're trying to unburden emergency departments and hospitals and say, you don't have to come to the emergency department, call your primary care practice. But if your primary care practice can't see you that day or even that week or month, that doesn't, it's one of the many problems right now kind of backing up our hospitals, including access to home health, long-term care, mental health services. Everything feels like it's kind of in a backlog right now.
And just an add-on point that to your question about why 12%, I think the balance, and I'm using that as a neutral term between specialty care and primary care, in general in this country has been 25% primary care-ish and 75% specialty care-ish for a long time. And it's, I think, across the country, we've been trying to shift that balance so that we have more primary care and less. But like you were saying, it's a slow ship to turn around.
All right, Bobby, you have the last word.
Oh boy, a lot of pressure. I was just wondering if the Vermont Medical Society has an opinion, or maybe you don't want to get into a political discussion about universal primary care. Well, it was once called, single payer. If we were to establish taxpayer-funded, guaranteed primary care with no cost to the consumer at the point of care, is that something that you think would actually encourage the opening of new clinics and perhaps new practices in rural and underserved areas?
Thank you for the question. We have talked many times about, so I do want to also distinguish universal primary care from single payer, because since single payer was intended to cover the whole range of healthcare services, so they are different, slight different proposals. On universal primary care specifically, we have been cautious because we have been concerned that it's typically not the coverage question that keeps people from accessing primary care services. Like most Vermonters have insurance or coverage of some kind that provides access to primary care, that workforce has been an issue. And then also one of the other concerns we had is fragmenting kind of our insurance coverage system. So if we're talking just universal primary care, then they might have coverage for primary care, but what does that include? Does it include the labs and imaging or follow-up care that might be needed? And then if they think they have insurance because they have the primary care coverage and they don't have comprehensive coverage, does that actually kind of exacerbate some of our problems? So it's not, certainly not opposed to taking another look at it. There have been some reports kind of looking at what this benefit might look like. Happy to revisit it or talk to you in more detail. We've been a little cautious about thinking that it's solving the biggest issues we have in primary care right now.
Great. Thank you.
Thank you.
Thank you. Please send our thanks to all your members and really the whole healthcare profession of the last couple of years. I mean, we hear all the time and we understand. So send our thanks. I highly recommend that if you have time this afternoon to stop downstairs for the Advocacy Day, talk to their members. You will hear what's going on the ground, and it's really important for us to hear their stories and what they do every day. So thank you. And I think we're gonna not take a break and switch. We'll bring Ina in. So we're still on air. Just give us a minute or two of transition time. Hi, Anna.
Thank you.
That's not, she was out in the hallway waiting. Good morning.
Good morning.
I think what I want to do before you get started, because we have some new faces in the room. We've introduced ourselves yesterday, but have those in the audience introduce themselves, just who you are, who you're with. We try to do that if I remember, which I try to do. So Mary Kate, do you want to start? Just introduce yourself.
Yeah. Mary Kate Molman. I'm Director for Vermont Public Policy for Bi-State Primary Care Association. We support FQHCs, those are federally qualified health centers, Planned Parenthood, and Vermont's free and referral clinics.
And she will be back with us. They also have an advocacy day on February 1st.
There's ice cream.
There's ice cream. It's all about the food and the ice cream. And we talked to Jessa.
Sarah Laughlin, Mickenberg, John Smith. We represent Health First and Green Mountain Surgery Center.
Great, thank you.
I'm Kristen Fountain. I'm the new health reporter at PT Digger.
Great.
Hi.
Hi,
I'm
thank
Kelly Vermont.
Great, welcome.
Not to get sick. Last week I was here and I was down to the count.
Oh, no, yeah, that's good.
Not here.
Yes,
You
yeah,
guys are all very.
we try. But welcome. Great, so as I said this morning, we are gonna pick up where we left off on the all-pair model. I'm gonna try and rein in the questions a little bit because I do wanna make sure that we get to what's facing us going forward, and then finish that all-pair model conversation today. So don't give me dirty looks if I cut off questions. And Bobby, again, I'm not sure we'll be able to see you. If we can, great. If not, text me if you have a question, please. Okay, so do you want to pull it up or you just want us to pull it up?
I am happy to pull it up if I know what to connect to.
So if you join the Zoom, do you still have that link?
Yes, I'm sure I do.
So going back to the slides from yesterday or different ones?
I think going back to the slides from
Just so I go-
yesterday
Yes.
and then moving to the slides
Yes.
for today.
Absolutely.
Great.
Yes.
Can I ask if my understanding of ACOs is correct based on what I learned last night?
Yes, you can. Good way to
So-
start.
I did some Googling last night and I want to see if,
That's gonna be a problem.
I know, well, that's why I wanted to ask, if my understanding of ACOs is correct. So what I found was a 2012 FAQ put together by some aspect of the federal government when they were first rolling this idea out and before they really, it seemed like before they had set the rules and everything. So there was a very high level overview. And based on that reading, it seems that and please correct me if I'm wrong, because I'm still trying to understand this, the concept under the ACO is that it is a legal vehicle to help avoid antitrust problems, and that it is essentially a legal vehicle, an organization that providers can come together and then use capitation in order to determine how much providers get for each patient in their practice. However, the bonuses and financial incentives are tied to quality improvement metrics and outcomes that are determined by, I'm not clear who determines those, but is that like at a very high level what an ACO is?
Those are components of the ACO. I would flip. Yes, it does provide a legal construct for there to be collaboration, coordination among providers without violating those antitrust considerations, and then to share in their potential financial savings. Everything you said is right. Okay. But I would flip and think of the ACO first as a structure to promote care coordination among a group of providers that are electing to come together to work collectively on healthcare improvement and outcome, and improving health outcomes. If we going back to the original ACO concept, which kind of grew up about simultaneous with all of the work that was happening in the ACA, I remember learning about it as a medical neighborhood concept. So graduating from the patient-centered medical home just being kind of around primary care to broaden that to include primary care and this larger neighborhood of providers, including, any number of provider types in the continuum. We've seen there are well over 700, more in the neighborhood of 800 ACOs in the country that are working, I think, particularly in the Medicare ACO program and the shared savings program. The large number of ACOs, they all, look different in terms of their composition of provider types. And we talked a little bit about the uniqueness of Vermont's ACO work yesterday. But I think I would first think about the care coordination and outcomes emphasis of that ACO structure. And then the legal protections are important tool for achieving the goals of the coordinated care program. But you named all the aspects of an ACO model, you named them.
Great, okay, great, thanks. I appreciate it.
Great. Are you ready were you able to get online while still
I am
asking that?
I am online. I'm looking, this is very meta here. Sorry, just wanna. Oh, great, okay. There we are.
So for those in the room or those watching, to find the presentation, go back to yesterday. Under Ina's name. We'll start off where we left off.
I think we might have left off with this slide yesterday. And so here's, again, discussing what we were just talking about, that this is a working definition for accountable care organizations. I think if you go and look with a Google search or look to the literature, that there are variations on this definition and theme, certainly from the federal government and the federal government's definition, they include a component about how the providers working in this structure can share in savings. That's a component of the Medicare definition specifically.
Would you mind doing a presentation view?
Oh, yeah, sure.
Those of us who are hard of seeing.
Hard of seeing.
At the very top, that thing looks like a little lectern with a play button. 4 icons to the right of the thing says on next to autosave. To the left.
To the left,
Yep.
Okay. Sorry, you guys are seeing my,
Directly above your pointer there.
I see chat, participants, new share.
Oh, we're seeing something different is the thing. We have to stop sharing your screen. I can provide technical support.
Yeah.
Great, okay. Let's see.
You can tell me how to.
So we
get
have
it
to move
larger.
this bar thing here is sort of getting in our way. And that's not, so I'm gonna, underneath this thing.
I think if you grab, you can move that bar down if
Yeah,
that's what
it's
you're
not,
trying to.
just stop
It's
sharing.
fine then, if it's.
Here we go.
Here.
Okay, so it went here, and then we're looking at this, and then we're putting it in slideshow mode.
The state of Vermont uses a Teams platform and not Zoom.
That's hard.
That's probably not an excuse for why I don't know Zoom better though.
I would use that as an excuse. I used to use Teams at my job and it's cumbersome.
I've spent a lot less time in Zoom.
I like Teams. I'm still used to Teams.
Yeah, got very used to Teams.
It was 15 when I lost it. There we go, it's this one. It's under this black bar, and I can't move the black bar.
I think
Okay.
I tried to
Don't know
move the
why.
black bar.
That's all right. Let's just go with what we have. Technology gets us every time.
There, I moved the black bar. Okay, so here we go. I think
There we
this
go.
will work.
Can I give you one more suggestion? Oh, you did it.
Yeah.
Did you
great.
get it?
Yeah,
Okay.
we're good. Thank you so much.
Okay, oops, I'm on the wrong presentation.
So I chose the wrong one.
That one's coming up later. One more try
I'm so
here.
excited for the next one, I skipped ahead.
Okay.
Great. Thank you. Sorry about
Well
that.
done, people. That was an ACO collaboration, right?
So we talked yesterday too about the work, what the work of the ACO looks like, or ACOs. The state has this high level agreement. It's a contract between the state and the federal government. And the reason the contract is important for us to have as we're looking at a payment reform model that's going to have the strongest and most aligned incentives, and also where we want to reduce, if possible, administrative burden. You know, thinking about those quality measures that we talked about yesterday as one example, where focusing on quality and outcomes, if those quality and outcomes can be consistent across payer types, as consistent as possible, then the signals for the healthcare system are stronger and are more and are fewer too. That's the administrative burden piece rather than, and I don't want to oversimplify here and suggest that we've gotten to a place where every single payer that a provider office is doing business with in the state of Vermont is focusing on the same exact quality metrics and the same, promoting the same outcomes, because Vermont's a part of a nation of states, and we have a lot of payers that are covering Vermonters that are national payers, and they have different rules and they have different contracting processes for provider offices. And we have also seen a lot more Medicare Advantage plans that are actively covering Vermonters in the state, and those plans too have their particular rules and expectations when they're doing provider contracting. So I don't want to suggest that if you walked into a provider's office and you started interviewing that office about, what the expectations are with all of their payer contracts, that they would say, oh yes, because of the all payer model, everything is now the same. But this is a step in the direction of providing more consistency or promoting more consistency. And we have to continue working in partnership and keeping that as a clear goal for the system, because it is, I do think that we have real evidence about the cost and burden of there being very disparate and competing requirements for quality improvement and for how providers are reimbursed as well. So when I talk about why we have a contract with the federal government, the really important piece of that is that contract allows Medicare to join in the state of Vermont and to align in this payment model that is tailored for our state. Medicare is the biggest biggest single fee for service reimbursement payer in the country. Medicare pays only fee for service for the most part, unless, there are some models that are episodes of care or bundled models that Medicare has implemented. But, largely speaking, Medicare is paying fee for service. So without an agreement like this, Medicare offers some ways that it will pay differently. Like it has its own ACO programs. And so a ACO in any state can sign up to be a part of one of those Medicare ACO programs. But those Medicare ACO programs are not necessarily aligned with the Vermont thinking around, and the Vermont hypothesis specifically, that if we shift more payments away from fee for service in an alternative model, and we move as far as we can in that continuum that we talked about yesterday towards that category 4, that's population-based payments, that is going to provide stronger incentives and more predictability for the system in how they're reimbursed. And that's why we want Medicare to be, in Vermont, the model that we have allows for Medicare to do more of that in alignment with our state objectives.
I'm gonna hold questions for just a little bit, so just write it down.
We'll talk about it as we continue talking today, but one of the key areas that we have identified for improvement in our payment and delivery system reform model, this all-payer model that we have today, and any future multi-payer model, is for Medicare to indeed make fixed prospective payments to providers that are predictable. What's happening in our model today is that the payments that Medicare is making, they are moved away from fee for service, but they still contain a component of reconciliation to actual fee for service. And that reconciliation complicates the picture. We want for Medicare to evolve and pay the way our Medicaid program is paying providers in this model. And we've talked with our federal partners repeatedly about that. We continue to uphold that as one of our strongest objectives for any future model. And it's something, to be frank, that we wanted to accomplish in the extension period for this model, but Medicare was not able to work with us to accomplish that change in the next 2 years time period.
Can you say that again? What change were they not able to accommodate?
When we were looking at this model years ago, we anticipated that we could tailor what's called the Medicare ACO Next Generation model to meet Vermont's needs. And when Medicare put that model out, their materials, their early materials said that there would be a capitation track of that model, which would be that fixed payment that has no reconciliation. It would be the payment, and then providers would work within it to meet the goals for cost and quality. What ended up happening was that Medicare kind of backtracked on the capitation and instead created a payment that's called all-inclusive population-based payments. And those are cash flow. Providers receive their money at the beginning of every month through the ACO model, but at the end of the year, depending on what actually happened, how many services were delivered, it is reconciled, which complicates the picture. It dilutes the incentives, because if you go over, you're going to get that money. If you go under, you're going to, pay it back instead of it being a savings that you can achieve. And then it's also an additional administrative activity. So we've been clear for quite some time with our Medicare partner that this is a key objective for the state, for Medicare to make these true fixed prospective payments. That is what our Medicaid program does. Our Medicaid program, you'll get the chance to talk with everyone at the Department of Vermont Health Access who have led in that work, and hear from them that they certainly designed the program using a capitation framework, again, because that is what we anticipated was going to be the Medicare offering, and we were looking at an aligned model. We think that our partners in the federal government understand where we are on this front. It does take time for them to change their payment models, and I know that the state will continue to push this as the highest priority for any future potential Medicare agreement.
Great.
So that
I just
reconciliation. I just say no,
Yes.
that's all.
Yes.
Yeah, I just we need to write down your questions. I appreciate that clarification. That was helpful to hear it the second time.
Yeah.
Yeah, so this contract that we have that says Medicare can pay differently in Vermont, Medicare comes to the table and says, yeah, well, we'll pay differently in Vermont and we'll kind of do it your way if you guys are accountable for some stuff. And we, Medicare, want to make sure that as we're working with states are going to, do things that we can potentially apply in nationally speaking. So that includes Medicare, wanting the state to have growth targets. And when we look at a future model, that's going to be something that remains consistent. Medicare would want to see in any future model that the state has total cost of care growth targets and commits to some kind of target for healthcare cost growth. And this is a target that's intended to moderate healthcare cost growth. As you can see, it's still growing, but it's growing less quickly than it maybe otherwise would. And in our agreement that we have today, the target is to grow less quickly than national growth by 0.2%, under national projections. And then we've talked about the alignment that's required. And the agreement also for Medicare to be at the table and say, yes, we'll do things differently in Vermont. They want to see really bold, and we would agree with these high level goals for improving population health, improving access to primary care, reducing deaths due to suicide and drug overdose, and reducing the prevalence of morbidity of chronic disease. And particularly now, relative to what has happened due to COVID-19 in terms of our social fabric, our systems for support, our healthcare system having to completely, needing to work and recalibrate how it does its work relative to a novel infectious disease. These goals remain very hot. I think that these goals are still very much applicable for us today. Whether or not they are the goals that remain in a future agreement, if there are other goals identified, that's still an open question, but I think that these goals remain important ones for us to have as objectives for healthcare system improvement in our state today. And to certainly recognize that these sorts of really high level population health improvement do take years to work towards and accomplish.
So let's take a break there. And are there any questions? Art had one first and then Daisy.
I have a bunch of questions. It sounds like, I had one question, but I think you kind of answered it, the fee for service and the value payment. It sounds like Medicare would work with you, and at the end of the year they'd reconcile, you mentioned. And
yeah.
I assume that would be if they did their job and did well, there'd be a big bump of money at the end of the year. Is that what they wanted?
Yeah, I'll use our Medicaid program as an example. There are providers that have selected to receive fixed prospective payments in the Medicaid program. And those payment amounts are arrived at between, back and forth between actuaries and looking at prior healthcare costs to project forward and anticipate what the cost should be. Once those amounts are established, let's just use the hospital as the example. The hospital that receives that amount, that fixed amount, that's all they receive. There's no change in that amount on what the actual experience was in the system, basically.
Okay.
There's probably some circumstances where that would have to, where adjustments could be necessary, but generally, that's the way that things work and are working in our Medicaid program. And we want to see the same with Medicare and commercial payers too.
Okay. One of the things that concerns me about this is the ability to attract physicians to come to Vermont, to practice in Vermont. And I can't help, and I guess it's my skepticism, I get nervous when the fee for service, if we're assuming that a doctor, a well-paid, well-trained, well-educated individual will try to do more surgeries than is healthful for a patient, it means we don't trust them. And I worry about that if we're going to attract good people to come here to practice medicine. And I wonder if that's any part of the discussion that goes into this stuff.
I think the question, like the system that the providers are working in, the system has incentives that can make it hard for, the incentives in the system can get in the way of providers sometimes having the flexibility the freedom to use their best clinical judgment and to do the activities that they may know are the most appropriate for an individual, like taking, the time, having the time available to make a phone call to another practitioner, for example, and say, hey, this is what I'm seeing. Can you tell me, have you seen this before? What do you, that kind of thing. Right now, the system, the way that it's working, doesn't pay providers for the time to make that call, even though that might be the best thing to do. It doesn't, the way the system is working, it may not allow the time for providers to do that because they're working in a system where they need to have appointments set at a very particular interval, and they don't have time to do the kind of things that might be more
follow-up type things.
Yeah.
And I would suggest, Art, if you have time again this afternoon with Vermont Medical Societies around, ask that question of some of the providers that are down
Yeah, no, I plan to if I can.
Great. Daisy, I think you had a question, and then Alyssa.
I have two. You referenced the variation in the ACO models, and how that can often depend on, the variation in contracting that they have with providers. You also mentioned that there was an increasing amount of Medicaid Advantage participants in Vermont. I think last I looked, I saw a number around 20,000 individuals. Is that right?
I don't want to commit to that number, but I do think it is, yes. So like when we were working on the agreement in 2016, I think the Medicare Advantage enrollment for Vermont, I don't want to, my memory is not going to be strong enough, but Medicare Advantage enrollment in Vermont has kind of lagged behind national, and represented a pretty small percentage of Medicare beneficiaries when we first started work on this agreement. That has been changing and changing rapidly. Vermont still, among the nation, our proportion of Medicare Advantage enrollees is much smaller than other states, but it's growing quickly. And so we have more Vermonters that have Medicare Advantage as their coverage rather than traditional or original Medicare, it can be called, or Medicare Part A and B, Medicare Advantage is Part C. That's what's changing.
So that caught my attention. I'm also really curious, how could we use Medicare Advantage contracting, such as the DSNPs or the special need? Is it special need participants?
I'm sorry, Daisy, I'm going to interrupt and say, can we hold Medicare Advantage just a little bit to the end, just so we can get through what the all-payer model is, and then bring Medicare Advantage in?
How can we use contracting, or what is our influence as a legislative body to use special contracting with programs to inform that process? So you referenced the variation in ACO programs across the nation.
Mm-hmm.
What influence do we have as a legislative body to shape that here in Vermont?
I don't know that as a legislative body that the body can prescribe how providers would choose to work with one another in an ACO model. But I also am not the authority, I'm not the legal authority on that question. But providers choose to come to, they elect to create an organization that is an ACO that meets the requirements of the federal government. If they're going to contract with Medicare, for example, or meets the requirements of the regulatory board in Vermont, if it's a Medicaid or commercial ACO, for example, in our state. So that's, private providers, private entities come together and decide that they're going to work in these arrangements.
And Daisy, we can ask that of ACO when we have them come in.
Okay. My second question is the quality measures on the right side of this slide.
Mm-hmm.
Can you speak to the alignment of the global commitment quality measures with these and quality measures that Medicaid also includes with models for integration of things like CCDHCs?
I think I can give you a high level answer there that we are working on payment reform models across the Medicaid program, and there are payment reform models that are active that are not just in the ACO program, and that there is a lot of work that's happening in the agency that's very intentional around aligning the quality measures for those programs so that they are more consistent and moving, in a similar direction. The payment reform team at Department of Vermont Health Access is a great resource that could talk more about what, precisely those measurements are and how they are thinking through alignment. But there is a lot of work there to try to make a consistent approach that is driving towards high-level population health improvement outcomes.
Great, we're gonna have Alyssa and then we're gonna move on.
So I'm looking at this slide and there's essentially two things that we're trying to do. We're trying to curb growth in spending, and we're trying to measure quality. So
and improve it.
Improve quality. So providers are paid, if you use a fixed payment model, and their quality is measured, and then they share in the savings. So ultimately, I'm just trying to figure out if a provider is able to curb growth in spending, let's say they even reduce growth in spending, what difference does their quality make? They're still going to share in the savings.
That's a really good question. And in fact, there are components we talked about on that other slide. There's, the ACO and provider contracts, and those ACO provider contracts have components of the contract that are at risk based on your performance and quality. So it's not sheerly, it's not just primarily, it's not just a fixed payment and then a measurement on the back end about what the quality and outcomes are, but there's also dollars attached to how you perform on the quality metrics. Does that answer your question?
Yeah, I think so. But also, speaking of quality and how you perform, can you explain in our current ACO model, are individual providers measured on their individual quality, or is it just the system as a whole?
There's different levels of measurement there, and in the, there are statewide population health metrics, and then there are ACO and payer quality metrics, and then there are, the ACO has contracts with providers that then also have a quality component. I can't talk in detail about each of those layers, but I know that there are, that you can have that detailed conversation with a variety of folks that are working on this model in the states. You can certainly talk about it with the group at DEVA that I mentioned. I'm sure that the Green Mountain Care Board, as it evaluates the ACO budget and certifies the ACO, that they are also looking at what the arrangements look like in terms of quality and can talk in a more detailed, way about what those arrangements are, the incentives that are connected to them. I don't have a deep dive on that prepared for today, but there are multiple layers that are intended to keep consistent these high-level goals. But like the question was asked yesterday, if the providers, aren't in contracts that are, aligned with the high-level goals, then will the model work? And we think it's really important that providers are in contracts that are aligned with the high-level goals. And that includes the goals, for providers to have flexibility and also the goals on quality.
Okay, sorry, Joe, we're gonna hold questions, so write it down and we'll keep moving along.
Okay, this graphic here, I wanted to share as background because I think this is sort of a depiction of the model and how it's working on the whole. Some of these things you'll recognize from the slide that we just looked at, but like we talked about yesterday, because this model is shifting risks to providers and is emphasizing prevention and wellness and intended to create more time and flexibility for providers working in these alternative arrangements to focus on prevention and wellness. We do think that it's very important that we have a strong foundation of primary care in the state of Vermont so that providers aren't shifting all at once to think about how to best emphasize and provide primary care. For other ACOs that have formed in the last decade, I think they've had to begin and define what their primary care approach is going to be. Here in Vermont, we had a basis of a primary care approach that was already a foundation for the work that the all-payer model could continue to promote in terms of more flexible payment. And so here I wanted to briefly describe that foundation, which is the Blueprint for Health program. You'll get a deep dive on this soon. But that program includes support that allows for research and co-design and implementation of healthcare payment and delivery models, innovative models. Some of those programs then are ones that you might be familiar with called the Hub and Spoke program for opioid medication assisted treatment for opioid use disorder. Primary care practices are supported in being able to offer medication assisted treatment along with wraparound services for those patients who need that care. The Blueprint practices in the state of Vermont are considered to be patient-centered medical homes. That means that they meet a standard for quality and care that is a national standard that's called the NCQA standard, and you'll hear more about that. And then, as I referenced yesterday, different in Vermont than in other states that have patient-centered medical homes. The Blueprint model has supported those patient-centered medical homes with dedicated resources for community health teams. And these health teams are comprised of community-based and social services along the healthcare continuum and can help to meet the health-related social needs of persons seeking primary care. And I just talked about the Hub and Spoke Women's Health Initiative is also a Blueprint program that provides, I think we talked about this yesterday too, for screening and high quality reproductive health care. And then finally, the Blueprint also has support for providers in this model where there's learning collaboratives, quality improvement, facilitation, and data-informed transformation to do all of this work. And a key component of the Blueprint, again, is that it is a multi-payer alternative payment model. Commercial payers, Medicaid, and Medicare. Now, Medicare participates because we have our all-payer model agreement. Dollars flow to the state through the ACO that then are allocated for the Blueprint for Health program so that Medicare can also support the community health teams and the patient-centered medical homes. And Vermont statute requires that commercial payers and Medicaid also support the primary care and community-based foundation. This is a very critical foundation, again, for promoting wellness and for continuing to move towards a more prevention focus. There are key partners in the all-payer model. We talked about our federal partner. Mountain Care Board has a critical role in the model in terms of oversight, the Medicare ACO program design. The board is the actual entity that can customize that design. And then it has shared with you some of its obligations around monitoring and reporting on the progress in this model. And that's where I urge you to hear from them. The governor and the Agency of Human Services also signatory of the model. It's our obligation via this contract to have the Medicaid program offer an ACO model, which is the Medicaid Next Generation program. And we're also leading in the negotiation of the potential next multi-payer agreement. ACOs, in this case, One Care Vermont and Vermont Providers, are key partners in this work because of their role in contracting with payers to accept these non-fee-for-service payments, contracting with providers that we've talked about, and providing their network with data, funding, best practices, and targeted resources and supports for improving healthcare delivery. And finally, private insurers, this is what we're talking about. Commercial insurers are also partners in this model in terms of their work to contract with, pay differently than fee for service, as well as to share about those potential contracts and opportunities with the self-insured employers that they often are working with as third-party administrators or administrative services only. And just like this is 5 boxes this is a significant undertaking requiring ongoing work across multiple significant stakeholders in the state. It really is a statewide model effort, and I think requires there is an element of patience that is required to do this work ongoing across these critical partners in the program. I wanted to share, we talked a little bit about the results of the program. It is independently evaluated. As I talked about, that's a key component of Medicare's relationship with the state, that it's going to insist on this independent evaluation. And in the first evaluation report, there are savings for the Medicare program that are clear. And there's also decreases in acute care stays and acute care days, and as well as there's a decline in specialty evaluation and management visits for the Medicare ACO initiative. And I think that's an important piece, that piece is one that we need to continue to understand relative to the access issues in our state when it comes to specialists that are a part of, when it comes to specialty care access. And there's that is an ongoing area of work and assessment to really understand what is driving the access issues in specialty care. And in the second evaluation report, I think it's critical to share that the evaluators, had to acknowledge that any evaluation results from a 2020 evaluation, which was when COVID-19, became, the pandemic began, have to be interpreted with just a huge amount of caution. And on top of that, there was also a cyber attack for the University of Vermont Health Network. But this evaluation report that was issued in December of 2022, it does raise up and emphasize that the providers that were working together in this model were more able to respond to the pandemic because of their network, working network. That's not something here in the quote, but it is something that the report includes at a high level in a summary. And it also observes that during this year, 2020, that the model maintained statewide chronic disease prevalence, increased the population that was getting initiation engagement of treatment for alcohol and other drug dependence and timely follow-up after ED discharge, and almost halved the percentage of Medicare beneficiaries with diabetes that were experiencing poor control. So these are early results, shifting healthcare payment and delivery models that have been, largely in place and have been the standard for, the history of our nation. Takes time, but I do think that there are some signals that that when we concentrate on some particular objectives, that there can be collective movement in the right direction, even if it is incremental, even if it is iterative change. And there's a lot that we can learn as we do this iterative change to help us continue to improve. It's continuous improvement on the model. Speaking of continuous improvement, we issued an implementation improvement plan. We don't need to work through the whole recommendations, but I wanted to emphasize that the all-payer model was going and some key areas where we wanted to see an acceleration of the work in the model, more incentives for transformation. And we were certainly seeing areas where transformation could be better supported. One of those things that I already talked with you about was the Medicare payment model. So we issued this plan and have been working on the plan, although COVID-19 and the ongoing pandemic certainly has interrupted some of the focus on the plan, and I think for good reason, because many of the folks who would be working on the plan were also involved with the public health emergency response.
You.
And many more important roles as well in terms of those who are providing direct service to Vermonters in the healthcare system. But the plan has 4 major components or buckets of work where we thought through what could we do with our federal partners to make this agreement work better? How could we work in the Agency of Human Services specifically to make this agreement work better? And how can we continue evolving the regulatory framework for value-based payments? That's something that I think you're hearing from the Green Mountain Care Board already about. And how can the ACO's leadership, what recommendations for the ACO leadership strategy in particular did we put forward? So those were the 4 main areas. And this is really for your reference to explore further there's multiple recommendations in each of the categories. And there has been progress on many of these fronts. There has not been progress on all of these fronts.
And I would think some of these are moving into your discussions of the next all-payer model. Yes. So I believe what we need to do now is move to the presentation that's under today's date. If you're following along on YouTube or here in the committee room, and while Ina moves to that, if you don't mind multitasking, Joe has a question.
Yeah, thank you. So my question is, going back to my notes here, because I wrote down, so who sets the quality metrics that members of the ACO need to meet in order to get the incentives?
The ACO negotiates contracts with payers, and each payer type negotiates those separately with the ACO, which I would say Medicare probably does the least amount of negotiation and the most amount of just these are the metrics. But I think you could certainly talk with, again, my colleagues in the Medicaid program and the Department of Vermont Health Access about how they undertake that work.
Okay, so it's a negotiation. Can a single ACO serve multiple payers?
Yes. Yeah, multiple payer contracts for sure.
Great.
Yep.
Thanks.
Mari has a question, then we're going to move on.
Can you send us the hyperlink to the NORC report?
Oh, yeah. Sorry.
Thank you. Yeah, anytime. And then is there progress on moving self-insured lives into the model?
Yeah, we can speak to the state employees were attributed to the model after these recommendations were made, for example, and that was a significant increase in commercial lives that were included in the model. The state employees are included in the Blue Cross Blue Shield. So, I think everyone is aware that Blue Cross and Blue Shield and OneCare have been asked to come back, have been encouraged to come to the negotiating table to see where they land for 2023. But prior to this, current moment, yes, there were some improvements in the number of self-funded lives that were a part of the model.
And you don't have to provide names, but other entities that self-insure other than the state employees? Is there progress with other groups?
I think it would be, I don't want to speak to all of the groups, but I know that there are other self-funded groups that are also included. And I know that Blue Cross and OneCare work together to devise a model for the Blue Cross self-funded business to be able to participate. Yeah, and then so it's broader than the state employees too.
So before you get started, I'm making a note. We keep talking about Act 167. And there are a lot of components to Act 167. So I just made a note that we'll have legislative counsel come in hopefully towards the end of next week before we get much more testimony on this and actually walk through the legislation with us. So new members can, and those who weren't here last year can get an idea of what's laid out in the legislation and then what our committee was thinking when we put it in place. So this is just one component of it that Ina's going to talk to us about now.
Thank you. And I'll share the full slides again. Sorry about that. I am going to focus today on the component of Act 167, which I think might be with Section 1, although I'm not certain of that, wherein the Director of Healthcare Reform in the Agency of Human Services, along with the Green Mountain Care Board, was asked to develop a proposal for a subsequent agreement with CMMI, with the Innovation Center, to secure Medicare sustained participation in multi-payer alternative payment models in Vermont. So that's really the focus of this update. As you'll learn when you work through 167, the Director of Healthcare Reform also collaborates with Green Mountain Care Board on some other key work where the Green Mountain Care Board leads on that work, but the Director of Healthcare Reform is coordinating and collaborating. Specifically, global payment method, the development of global payment methodologies, as well as sustainability for Vermont hospitals. But again, the theme today is the federal state agreement. Let's see if I can advance the slide. Okay, great. The Agency of Human Services wanted to approach the work to start looking at a future potential agreement by convening with a healthcare reform work group. And this work group was established with key stakeholders in the healthcare reform sector early in the summertime, just not long after the legislative session. We've talked today or a number of times about the way that the pandemic has caused so much disruption, across sectors and particularly in the healthcare system. And so I wanted to highlight that it was important that when we brought the work group together to think about a future all-payer model or multi-payer model, that we also spent time with the group addressing some very near-term concerns because the stability of the healthcare system has been undermined significantly due to the pandemic, and the pandemic has certainly exacerbated weaknesses in the healthcare system. So we spent time talking about some short-term strategies for provider stability impact of the regulatory environment on stability, and I mean the federal regulatory environment is largely what was discussed with the group, and then talking about the financial and care model, and that's the multi-payer model, or the model where payers are paying differently with the intent of providing for incentives and structure and investment to support changes in care delivery. The work group will also take on and incorporate into its ongoing work the Act 167. It will be connected to the Act 167 requirement to consider the long-term stability for Vermont's hospital system. In terms of the short-term stability, provider stability, first there was a subgroup that met on this aspect, and the group met 6 times between July and August and generated a number of recommendations. You may want to hear more about these in a later discussion. AHS committed to a number of actions across 4 categories to include workforce regulation, and the regulation activities again involve work that we've pursued with our federal partners, specifically around skilled nursing facilities and waivers that were in place during the public health emergency that have since been sunset, and make it much more difficult for skilled nursing facilities to have the medical directorship that they need in order to operate safely, more difficult for those facilities to support patient care with advanced practice professionals, for example. We also talked and have talked with our federal partners, including the administrator of CMS, about the home health care rate cuts that have happened recently and are also a threat to the stability of our system. System flow and revenue were also part of the actions. So this is a summary of that work. I wanted to be sure that the committee was familiar that this is really an important component of any healthcare reform work that's happening, meeting providers in the system where they are, which is often in very discouraging moments when the system is not functioning the way it was prior to the pandemic. And again, prior to the pandemic, there were lots of places for the system to improve, but there was erosion in those weak places. Financial and care model. So now kind of talking about the proposal for a subsequent agreement with CMMI to secure our sustained participation with Medicare. This group, the healthcare reform work group, met 4 times between August and November on the topic of a proposal for a subsequent agreement with CMMI. And then from those meetings, we generated 2 subcommittees. Those subcommittees focused on a global budget subgroup, as well as a total cost of care subgroup. And when you hear about what the priorities are for our federal partners for a subsequent model, I think that these subgroups will make more sense to you. But first, let's talk a little bit about the timeline and pathway. We have our original, there was an original agreement that we talked at length about. Then we have an extension of our current agreement. And then beyond 2025, we anticipate that there could be a future Medicare multi-payer agreement. It is, the state of Vermont's choice to participate in a Medicare model of this kind. And I will emphasize that choice. And I will also share that there have been voluntary Medicare models that states were selected for, particularly around critical access hospital and hospital transformation. And when the rubber has met the road and it's been time for the hospitals to launch in that work, due to the pressures partly of the pandemic, but partly to how that model has ultimately been designed, hospitals have declined to participate in that at this point. So I think it's important context to understand that our federal partners are very interested in reform, but that the states ultimately do have the states need to evaluate what the federal government is offering and needs to do that really critically to ensure that it is in the best interest of the state. So when we think about the engagement on this work and the work that we have to come, we engaged with the work group through August through December of 22. During this first phase of engagement, the AHS convened with the work group and these technical or subcommittees to provide initial feedback to CMMI on its priorities for a future multi-state alternative payment model. We were working at a pretty feverish pace on this front because we actually understood that CMMI was going to pull back from engaging with the states at the start of the new year so that they could run a potential future model through a clearance process in the federal government. Typically, these clearance processes mean that the CMMI the officials can't engage directly with the states at that time. We, along with other states, we relayed a lot of concern about this. We didn't understand enough about what the parameters of a potential future model could be for the state of Vermont. We were concerned about what some of the parameters would be, and we, along with other states, advocated that the federal government take more time working directly with states. So this timeline here reflects our successful advocacy on that front. CMMI is going to continue engaging with Vermont so that we can inform what they might offer in the future, and we have that opportunity to continue working with them through the midsummer. So the second phase of engagement here, I think it's January through mid-2023. AHS and the Green Mountain Care Board will maintain this engagement with CMMI over the next 6 months and will continue to provide feedback on what multi-payer model design could look like for Medicare to join a model in the state of Vermont. And during this period, we're also looking to seek broad stakeholder feedback through public comment, community engagement, and other forums that are going to be designed to capture input of Vermonters. And then based on all of that information, we would expect a formal opportunity to talk with Medicare about a future model to be available at some point in 2023, likely in the latter part of 2023. And we also at this juncture expect that the state would need to submit a proposal in response to this offering. We talked about this slide yesterday. I wanted to share it again here today just to emphasize that Vermont has been successfully collaborating with CMS over many years now to be a leading state in implementing alternative payment models through the blueprint, through our participation in SIM and shared savings and the all-payer model. And we do know that CMS looks to us as partners in co-design of these models. And we are also working really hard to build on the strengths of these models while improving on what we can do in the future. One of the things that we talk about quite a bit with CMMI is, Vermont, when evaluators come to look at Vermont and how it's doing on, NORC, because they're looking at the all-payer model now, they kind of scratch their heads, and you can read in between the lines of the evaluation, they often mention it's hard to attribute it's hard to attribute this outcome entirely to one thing that's going on because Vermont has so many layers of good work that it's done over time. And we're continuing to talk about this with CMS. I think it's really important for us to highlight this and also for us to help them think about how they would evaluate a model in the future, because we do have some strengths that should be rewarded and incorporated as we continue potentially working with Medicare. And these are some things we've been sharing with CMS. We're one of the oldest and most rapidly aging states in the nation. being older is associated with negative health outcomes. Healthcare spending should be high if you follow that logic, and total cost of care should be high. But Vermont is actually one of the healthiest states in the nation. We enjoy high rankings on a number of lists and scorecards, and then similarly, we are the lowest spending Medicare state in the nation. We spend less on Medicare than any other. We really want to emphasize this with our federal partners as we're talking about continued reform, because I think there's a key question. It's really important that we can continue to be creative with Medicare as a partner, but that for Medicare's expectations that the lowest spending state become even lower is not realistic.
So we're going to stop, but Ina has to be somewhere at 11 to testify in another committee, and I really want to get us to the next section. So I'm actually changing my mind about stopping. Can you both hold your questions, and then let's go through the next section, because this is really about the next stage.
Yeah.
And we'll hopefully have time.
So in the next stage, CMS has 7 priorities for a model, and Vermont ticks some of these boxes already in our current, but not all of the boxes. So CMS wants to see global budgets for hospitals in a future Medicare model. How those global budgets for hospitals are administered is a question for the negotiation. But there's no, in this model that they're going to put forward for multiple states. So Vermont has our own model right now. So does Maryland, so does Pennsylvania. We're 3 states in the nation that have custom models. CMS would like us to come into a group at least, so that they're not administering 3 separate custom models, and that they have a group of states that are doing all payer or multi-payer reform. We're really trying to move towards multi-payer, because all payer is a bit of a misnomer. We're never going to get all payers doing the same thing. So global budgets for hospitals is a priority for CMS moving forward. It's also something that Act 167 required work to develop methodologies for that. So there's alignment with that requirement. There should be a total cost of care approach. We have a total cost of care model today. The model should be all payer. This actually should have been updated. It should be multi-payer. Everyone shifted to multi-payer as of December 15th. So this is an old slide, I'm sorry. Including goals for minimum investment in primary care. And Medicare also acknowledges that it has been underinvesting in primary care, including safety net providers from the start. Of the agreement addressing mental health, substance use disorder, and social determinants of health or health-related social needs. And that model, really, this list could be flipped to say that addressing health equity is the first priority for these models. And Vermont is sharing with CMMI that we envision a portfolio approach to be able to implement a model of this kind. And this draws on current work that's happening in the state, where there are broad state total cost of care targets. There are ACO total cost of care agreements with payers. And then there are also particular payment models that I talked about happening in other spaces that could be better connected, like specifically Medicaid has alternative payment models in other areas, other components of the healthcare system, where we think there's an opportunity to better connect to the broad statewide objectives. We also have seen, we've been talking about quality today, where there could be an increased emphasis on quality bonuses and potentially penalties that are coming closer to the individual providers and are not as, so they're coming down at a closer level. And specifically here, that those quality bonuses and potential are related to providers that are specifically collaborating together like, for example, to be illustrative, not because we have a plan in mind, but thinking about how primary care might collaborate with specialists, for example, to better meet the overall needs of the population, that there could be a payment that could bridge that, that could incentivize that collaboration specifically and help to bridge that work between those specific provider types. We also are emphasizing with CMMI some critical points. We touched on these already. We are a low spend Medicare state, and we are experiencing declining financial margins because of COVID-19, inflation, other factors. A future Medicare payment model needs to reflect the actual costs to deliver care and provide financial sustainability for participants. Basing a Medicare model on what's happening today, for example, does not reflect the cost of care. Today, people are ending the year in the red. If you built a budget on a year that ends in the red, there's nothing sustainable about that. Throughout the current model test, Vermont has also maintained lower Medicare spending growth than the national average. So we have moderated Medicare spending growth through the term of this model. Prior to the model, we were growing for a couple of years more quickly than the nation. Since we implemented the model, we have consistently grown less quickly than the nation in terms of Medicare spending. Any future Medicare payment model needs to give us credit for our performance versus an expectation that we would enter a model and have to deliver additional savings from the start. We have saved, we're small, but as a state, we are very low cost for Medicare. And we want to see more Medicare investments in primary and community-based population health programs. And we need to not only maintain the investments that Medicare is making in Vermont in these programs today, we need them to increase those investments.
Yeah.
Okay.
And then I referenced that there were two subcommittees, and the Green Mountain Care Board is going to be talking with you a lot more about the global budget work. So I'm going to defer to them and just kind of give you a high level overview. These committees focus on global budgets for hospitals as well as total cost of care. The total cost of care committee really explored those themes that I just talked about. Like if we're going to be held responsible for a total cost of care target, that target needs to acknowledge where we are relative to other states and Medicare spending, and needs to acknowledge that we need systems investments. And there are a whole variety of ways that we think that we can be partners in negotiating what would be a reasonable growth target that would continue to moderate healthcare cost growth without threatening the sustainability for our system. When it comes to the global budget model for hospitals, some high level themes are we need to have flexibility as a state to be able to design and implement hospital global payment and budget models. And we would advocate that any federal model doesn't prescribe doesn't prescribe and restrict the state, but rather gives the state the flexibility, and that the maximum amount of flexibility is really what we desire and need in this work. And I think we've likened it to how we work in the Medicaid space with Medicaid as a federal partner. People say every state Medicaid program is one state Medicaid program. They're all very different because it's a state federal model. Each state does it differently. We're trying to say to Medicare, you can do things differently in each of the states. Each of the states have different needs. Now that's only going to go so far, but I think that there is an opportunity potentially for Vermont to have some flexibility if it were to proceed with administering a global budget model. There's a whole lot of work to do between
here and there. By no means am I sharing this to indicate that we are committed to the global budget model at this time, but it is something that we will continue exploring and to be exploring in a much more robust way with a broad group of stakeholders. So we will continue our weekly meetings with CMMI. We also meet on a monthly basis with the director of the Innovation Center. We are going to see with the Green Mountain Care Board, there's going to be a technical global budget work group that's going to get even deeper into the weeds of global budgets for hospitals to continue to be informing CMMI about the needs and the potential framework for a state like Vermont if it were to choose to participate with Medicare. And that work is launching very soon. We're also launching a Medicare waiver focus group. We didn't talk about this very much at all, but through these models, Medicare actually does provide for waivers and flexibility so that providers can do things differently. And in some cases, beneficiaries can access care and services that they otherwise would have different coverage requirements around. So I think you should hear more from other folks about the waivers specifically today. But one example of a waiver is that, with in original Medicare, for an individual to be able to go and to receive skilled nursing facility services, that person has to have been admitted to the hospital. We know that that's not always appropriate, that and broadly, that's understood. Medicare is willing to waive that requirement for ACO participants, and that is something that's active and is happening in the state of Vermont. We're interested in knowing through this waiver focus group what other like Medicare payment rule and regulation are particular barriers for doing the best work on behalf of Vermonters. There's another ACO program that's called the REACH ACO model, for example, that allows for advanced practice professionals to bill Medicare directly, so that everyone in a practice can be delivering care for Medicare beneficiaries that's consistent with their license and training. So this is an exciting piece of work. I get excited about the Medicare waivers.
Like someone does.
And then there will be town hall meetings and other forums to describe this approach more broadly to the citizens of our state.
Thank you, Ina. This was very helpful. One of the very most frustrating things about our roles is there is never enough time. So Todd Brewer is going to ask a question, and then we do need to let Ina go because she does have testimony in another committee. Keep your questions. Happy to talk offline, one-on-one, and we will keep coming back to this, but it was a good overview. So
I'm hoping this is going to be a very short answer. All of everything that we've heard today sounds wonderful. And I'm going to talk from a consumer. How am I going to know when the costs have been controlled and the quality of care is maintained? Because honestly, since the ACO has started, my costs for healthcare have gone up, and in some cases dramatically. So how will the consumer know? And if that's too long of an answer.
No, I think that, first of all, this is one health reform initiative. It is a large health reform initiative, but it is by no means the only healthcare reform initiative. Like I said yesterday briefly, that this initiative paying providers to so that they can transform how care is delivered for it to be more efficient and a higher quality. It doesn't include prescription drug costs. And I'm not intending to suggest that prescription drug costs alone will change your experience and what you're paying, but it is a huge component. So there are there are multiple initiatives that do have to happen together and we have to continue working on these pieces to try to influence healthcare cost growth. But healthcare cost growth is and has been moderated in the state of Vermont. We have evidence of that, whether or not, and then I think we also need to ensure that the care quality is also continually being improved. There's continuous improvement and opportunity to do better for the people of the state. So, being realistic, I think healthcare costs are going to continue to grow. What we really want to see is that healthcare costs start to grow at a level that is more aligned with overall economic growth. And that's where we have to have an emphasis. So healthcare costs need to grow more slowly than they otherwise would grow. And I think we have some of that work is happening, and there is much more of that work to continue.
And I would also just add some of what we learned yesterday when talking about insurance companies. This is reform for the state. There is also a lot that comes from the federal government that affects the insurance policies that are offered to people. And those costs at a federal level keep rising, which means our costs keep rising. So it's definitely multifaceted, but an extremely important question. When will we see it? So I think that's good for all of us to keep in the back of my mind as we hear from everyone throughout the session.
And the impact of pharmaceuticals is huge.
And the impact of pharmaceuticals is very large on our plans, which we will, I keep saying eventually, I promise we'll get there. We will eventually have, folks in to talk about that. It's a big part of the increased costs that we see every year. So Ina, thank you. I know you have to go. Please apologize to the other committee for us. And we appreciate your time. We will take a break. We are back at 11:15 for Ameren and I think Katie to walk